4, 3, 2, 1. Sir, we are live now.
So thank you, Maharshi. Maharshi is from Ortho TV. Our friends Neeraj and Ashok, they are helping us. Now, I would like to invite Joannes. Dr. Joannes James, our current fellow, and so as Dr. Tashveen Rubayat. Joannes, please
Yes, sir.
take it from here.
Yes. Thank you, sir. Uh, Thank you, Maharishi. Uh, Good morning, everybody. Today we'll start off with a new module on pediatric tumors. We are rejoining after a short break after the POSICON. Today, the first session is on imaging in pediatric bone tumors, and we have Dr. Ankita Ahuja and Dr. Malini Lavande from Innovation Imaging in Mumbai. And both of Innovation Imaging is a premier institute in Mumbai for MSK imaging, and both of them are involved in teaching in their centers and also through fellowship and observerships. And we are on behalf of the fellows academic rounds and Orthokids, we are grateful to both of them that they could spare their time and join us. And for the panel, we have Dr. Ankur Shah from GIC Ahmedabad and Moulin sir, and Dr. Mandeep Shah from Sparsh Hospital, Ahmedabad. So the first talk will be by Ankita ma'am on reading pediatric bone tumor radiographs. Ma'am, you can share your screen.
Okay, I'll go ahead. Thank you so much for the invitation. It's a pleasure to talk on an important topic, actually. So, should I start?
Yes, ma'am.
Okay. So, good morning, everyone. I believe everyone is awake. I don't know how often do you have morning rounds, but I believe half of the people are sleeping at still. So let's begin and let's discuss some basics. I think these are some basics which are really important for us to go forward. So if you talk about bone tumors, the first thing which you all need to understand, or everyone needs to understand, that radiographs form the basis of bone tumors. If you want to see any imaging, radiographs is a must. So you should always start with radiographs, right? So sometimes even on radiographs alone, you will come to a diagnosis and you might not need any further imaging in a certain cases. But you may need a further imaging, which would be an MRI or a CT, depending upon the case. That doesn't let you ignore the radiograph. So radiograph is the most important modality for investigation. So we should know how to approach a radiograph, right? What you are looking for. So this is a very simplified approach, which will help you reach usually a diagnosis or a differential diagnosis. So first step is, whenever you see a radiograph, you have to identify whether there is any abnormality or not. If you have picked some abnormality, next step is to look at the age and location. So if you are most of your orthopedicians, then the patient is sitting in front of you and you know the age, right? But for radiologists, sometimes the age might not be printed. So you look at the faces and correlate whether it's a young patient or an adult patient, or else you figure out what's the age of the patient, because it makes a real difference in the further steps. Then next step is to look at the location of the lesion. Sorry. Following which you try to characterize the lesion as either an aggressive lesion or a non-aggressive lesion. Following which you try to further characterize the lesion so that you reach a diagnosis, right? So let's start following the same steps. So the first step, this is a radiograph. So we all can see that there is some extra sclerosis happening over here, some ossific stuff going over here, with some soft tissue ossification as well. So we all are very clear that we know a case which has a identified abnormality which we can see. So the next step we move down to is to look at the age of the patient. So if you all can see, this is an immature skeleton. So you are very clear that you are dealing with something which is a young patient, which is a pediatric patient. So the skeleton has yet not matured. So your differential diagnosis will come down to a lesser number than a bigger number, right? So you would not think of Mets, myeloma, lymphoma, which is usually a diagnosis which you think in an elderly patient. In a pediatric patient, your differentials would change depending upon the age. So always keep this image in your mind, because this will help you make a lot of diagnosis, right? Then the next step is to look at the location of the lesion. By location, what do we mean? We mean by location whether the lesion is in epiphysis, metaphysis, or diaphysis. So this is one longitudinal location which you want to know. Also, what you want to know is whether the lesion is cortical, juxtacortical, or medullary, because all this will again make a differential change. Now let's see how it makes a differential change. So we are going to focus on this side of the chart. So if you see, if the lesion is in epiphysis, your diagnosis would usually be limited to very few differentials, which would be chondroblastoma or infection, right? If the lesion is in metaphysis, then you can think of whether the lesion is aggressive or non-aggressive based on that osteosarcoma, ABC, NOF, CMF, or enchondroma. Again, if you move down to diaphysis, you might think of SBC, FD. If it's aggressive, then Ewing sarcoma, eosinophilic granuloma. If it's cortical based, this was the longitudinal stuff which we discussed. But if it's cortical, then you're thinking of osteoid osteoma, osteosarcoma, cortical, you're thinking of non-ossifying fibroma. So your diagnosis really changes. This image in your mind will help you reach a better diagnosis or a differential diagnosis. So now what we learned was the next step to identify the age. We decided that this is a young patient with an immature skeleton. The location of the lesion in this case is metaphysis. So we have moved down 2 steps forward. Now the next step which we need to take is to decide whether the lesion is aggressive or non-aggressive, right? So why do you want to do that, right? Till now, whatever we do has a motto, right? So next step, what we are trying to do is to figure out whether it's an aggressive lesion or a non-aggressive lesion. Why? Then you have a list of entities which you need to think whether you are looking at aggressive lesion or a non-aggressive lesion. So in a non-aggressive lesion, this would be your list, and we'll come down to the list a bit later, right? For now, just keep in the mind. And the red boxes indicate more of the lesions which are more common in the pediatric population, right? And then similarly, if you have an aggressive lesion, then the list comes down to really limited things which you can think of. Usually these would be in elderly, red box in pediatric, and in pediatric, you need to add on a neuroblastoma, mets, and leukemia to your differentials. So your diagnosis, things which you need to think of becomes really limited. Now, how can you do that, right? So how can you characterize something and decide whether it's aggressive or non-aggressive? So the most important step in that is to identify the zone of transition and the periosteal reaction of the lesion. So we'll come on to all the 5 steps slowly, but we'll start with these 2 steps, that is zone of transition and periosteal reaction, which are really very important to understand whether the lesion is aggressive or non-aggressive. So let's start with the step 1, which is the zone of transition. What do you mean by zone of transition? So it's basically whether you can draw a line around the lesion discretely from the rest of the bone or not. If you can draw a line discretely, that becomes narrow zone of transition, and that's a non-aggressive lesion. If you cannot draw a line discretely around the lesion, then it becomes a wide zone of transition and it suggests an aggressive lesion. So let's see the graphic understanding. So in this case, purple thing represents the bone and red block represents the lesion. So the lesion is very well delineated. So this would be a non-aggressive lesion. If the lesion is lined by a white border, which is sclerosis, then it again falls into the category of non-aggressive lesion. But if you cannot delineate till where the lesion is going and it's so ill-defined and it's breaking the cortex or it's just going like a moth-eaten appearance, then it becomes aggressive. Now let's see example of everything, right? So here is a lesion. If you want to draw a line, you take your pen and you are able to draw the line along all sides of the lesion. So this becomes your narrow zone of transition. Similarly, in this case, if you draw a line, you can draw a line all along. Actually, in such a case, you don't need to draw a line because there is a sclerotic border which is already drawing a line around the lesion. So that makes the lesion very well defined with a sclerotic margin, making it non-aggressive. So how would an aggressive lesion look like? So if you look at this lesion, you can see definitely first step identification has been done, But if you see, you are not sure till what level here the lesion is going. You can only see this, but the lesion is all over here, and you really don't understand till what level the lesion is going over here, right? So this is kind of a moth-eaten appearance, which we are seeing along the shaft of the lesion, which suggests an aggressive etiology. Also, there is this lesion is bursting out, there is cortical erosion, which again supports that this is an aggressive lesion with a wide zone of transition, right? You cannot draw a line over here. So this is very, very important, and this would really help you taper down your differentials later on, or at least decide between aggressive and non-aggressive. Again, in this case, if you try and identify the lesion, you can see that the lesion is this lytic areas, but there are lytic areas scattered all over. You cannot really make out till where is it extending. Is it till here or it's still here only? You don't know. You don't know where to draw the line. So this is a wide zone of transition, and this makes the lesion aggressive, right? But as you know, all rules are now not always standard. So there are always star marks, like in all the policies you have. Similarly, you have all some star marks over here also to the rules. So if you see a narrow zone of transition, still in elderly patient, you will think of Mets myeloma. In a young patient, if you see a wide zone of transition, still you need to think of tumor mimics, that is your infection and eosinophilic granuloma. GCT, you will usually see it is really well defined, but it is actually a locally aggressive lesion, and you all would be knowing it can have soft tissue deposits as well along the tract of surgery and everything. So it looks well defined. We will make it fall into narrow zone of transition, but ideally it's not a really non-aggressive lesion. It's a locally aggressive lesion. Now moving on to the next most important thing which we need to do is periosteal reaction after looking at the zone of transition. So again, if you see a solid unilamellated periosteal reaction, that's non-aggressive. And whatever else kind of a periosteal reaction you see, whether it's multilamellated, interrupted, spiculated, or Codman's triangle, it suggests an aggressive etiology. So let's see a few examples. So in this case, this is a solid periosteal reaction. So in this case, you can see that this deep thing is your cortex, and this overlying thing is a thick solid periosteal reaction on either side. It's so thick and homogeneous. So it is kind of a solid periosteal reaction, which suggests that the pathology is usually an non-aggressive pathology. Similarly, over here on this example, you can see this is the cortex and this is the overlying solid thick periosteal reaction which we can see. So this suggests a non-aggressive etiology. Then if you start to see multilamellated, like in this case, we discussed that this has a wide zone of transition. And if you see, you can see the multiple lamella which are seen over here. So this suggests a non-aggressive etiology. Sometimes if the tumor growth is very fast, then this may interrupt this and break the periosteal reaction. So you get interrupted periosteal reaction, right? And then lastly, you can have your Codman's triangle, which is actually a single periosteal reaction, which got interrupted by the soft tissue growth because the tumor is growing at a very fast rate. So it interrupts the periosteal reaction, resulting into single interrupted periosteal reaction. So all these types of periosteal reaction, and lastly the sunburst one, which is really aggressive. So it is growing against the bone and growing in a different direction. So this suggests very aggressive lesion, right? So these are the two important steps which help you come down to a diagnosis of aggressive versus non-aggressive. So if you no periosteal reaction without fracture in these lesions. So this is something which you need to remember. So these are all non-aggressive lesions and they should not have usually a periosteal reaction until unless you see a fracture associated. So we have discussed these two steps to decide aggressive versus non-aggressive. So coming back to our case, which we saw, here we saw single interrupted periosteal reaction and we cannot delineate the margin of the lesion. So it has a wide zone of transition and a single interrupted periosteal reaction, which both point towards an aggressive etiology. So we have come down to approach we have reached to differentiate between aggressive and non-aggressive. So now we know which list to follow of the two, right? Then to further characterize, you can see list says the matrix and the opacity of the lesion, right? So we need to understand the opacity and matrix of the lesion. How do you do that? For opacity, it can be either lytic, that is a lucent lesion. It can be either sclerotic, like in this case. So this is an ABC. In this case, you can see a sclerotic focus over here, or you might land up seeing something which is patchy, lytic, and sclerotic. So this is your classic OFD, which is a cortical based lesion. So you have to follow all the lists simultaneously. So it can be either of the opacities. Then you move down to matrix. So matrix can be either osteoid, chondroid, or a fibrous matrix. How do you decide that? So if you see something which is really cloudy, thick, dense, then that's an osteoid matrix. If you see rings and arcs within the lesion, so as per my experience, I've always realized within the center of the lesion, you'll not be able to identify the matrix well. So see at the periphery of the lesion. So you will be able to see the rings and arcs much more beautifully. So this is kind of a chondroid matrix with classic rings and arcs all over. Or you might see just a subtle ground glassing all along. That is your fibrous matrix, right? So this is a case of fibrous dysplasia. Or sometimes you may see a lucent lesion like opacity. We discussed lucent similarly. So that doesn't have any matrix. So that's a no matrix or a lucent lesion. So if you discuss these steps, you will come down to a further narrower differential diagnosis. And lastly, what you need to assess is to look for any soft tissue component associated or not. So in this case, you have an osseous matrix with associated soft tissue component. So you know it's an aggressive lesion. So these are the steps which help us come to a diagnosis. So in our case, it was an osteoid matrix aggressive lesion with soft tissue component, which according to the list, so if you think in a pediatric patient, osteoid lesion with aggressive is only one, that is osteosarcoma. Lastly, if you see multiple lesions, then your differential diagnosis has to think and take into account these etiologies which have multiple foci, which could be vascular lesions, either benign or malignant, or could be multiple enchondromas, or could be fibrous dysplasia, right? So these needs to be kept to account. In elderly, there are other things like Mets, myeloma, lymphoma, parathyroid. But in pediatric, most commonly would be multiple enchondromas, fibrous dysplasias, or vascular lesions. So let's just quickly have a look within next 2 minutes at few cases and apply the approach. So all are pediatric patients, right? So do you see this is a well-defined lesion? So this has narrow zone of transition. It is expansile, but there is no periosteal reaction as such, right? So you know that you're dealing with something which is non-aggressive. Then you have first of all seen the location, which is the epimetaphysis, right? So you are left with your differentials of something which is in epi and metaphysis. So either chondroblastoma, or at most you can think of an ABC, right? So these are the two differentials. But if you carefully look at the lesion matrix, right? If you see some rings and arcs towards the periphery of the lesion, so which suggests that there is a chondroid matrix. Epiphyseal chondroid matrix, you have only one differential left, that is chondroblastoma. So this was a case of chondroblastoma. Similarly, in this diaphyseal lesion, narrow zone of transition, you can draw a line here, you can draw a line here. There is a small fracture here, but still no periosteal reaction. So put into non-aggressive category, diaphysis. So non-aggressive diaphysis, you are left with FD and SBC in the metaphysis. If you look at the matrix, it's a little confusing, but it was predominantly cystic, and that's where the role of MRI will kick in soon. So either it can be an SBC, or either it can be a fibrous dysplasia, but this is more lucent, so it was more of a SBCs, unicameral bone cyst or a simple bone cyst. Then another example, this is classic ground glassing. So once you see classic ground glassing, you are not left with much differentials. You know that this is fibrous dysplasia. Then cortical based lesion, which is very thick osteoid kind of a matrix. So you're left with osteoid lesions in the cortex. Which would that be? Nothing else except osteoid osteoma. but you need to see the history and everything into picture. In such a case, you will involve CT to look for the nidus, because this can also be the appearance of stress fractures, right? Then you see narrow zone of transition with chondroid matrix. You know you're dealing with N-chondroma in this location. Then again, you have a metaphyseal lesion. Sorry, the chart is missing from here, which shows metaphyseal lesion, which could either be a lytic lesion with some probable chondroid matrix with little expansion, makes it favorable to CMF rather than an OFT, right? Moving on to the other cases, then you don't see wide zone of transition, aggressive periosteal reaction. In a diaphysis, you are left with Ewing sarcoma, metaphyseal location, aggressive reaction, some uh, matrix over here, difficult to identify, but a young patient. So you have to think of OGS, a telangiectatic form. This we discussed as a classic OGS. This is a case of neuroblastoma mets, but it would be difficult to identify on radiograph. If you see here, there is some lysis over here, and then MRI gives the clue, which I'll leave, which would be discussed later. And the last slide, which shows that you have to think of tumor mimics, right? You have to think of tumor mimics. So a wide zone of transition, but a narrow zone of narrow type of a periosteal reaction, or a non-aggressive type of a periosteal reaction. So it's not matching. So your zone of transition points towards something which is aggressive, but your periosteal reaction points to something which is a non-aggressive thing. Whenever you feel this mismatch, always think of tumor mimic. This is kind of a clue which we have realized in our practice. Then there is a mismatch between a zone of transition and periosteal reaction. Usually you're thinking of a tumor mimic. So this was a case of osteomyelitis. And again, you see a narrow zone of transition over here. You can well delineate, but this is kind of an odd periosteal reaction. You can see some tunneling happening over here in the diaphysis. So actually not even narrow. You see some bits of this going here as well. So wide zone of transition with a cortical tunneling with some periosteal reaction, which is probably interrupted. So it's a mix of, it's not something which is very clearly to be put into why aggressive or non-aggressive. In diaphysis, in a kid, we only know of something which is Ewing sarcoma, which is common. But this is not fitting into Ewing sarcoma. There is no soft tissue component. So you think of something which is again in the same location and a tumor mimic, which is your eosinophilic granuloma, right? So just to sum up, radiographs, do not miss the radiographs. Radiographs are the most important thing to be evaluated whenever you are looking at any case. You should start with radiographs, following which you follow a systematic approach. Look at location, age, identify the lesion, decide between aggressive and non-aggressive based on your periosteal reaction and zone of transition. Look at the rest of the features and come to a reasonable diagnosis or a differential diagnosis. And never forget your tumor mimics, which are your infection and eosinophilic granuloma. Thank you so much. Sorry for a little hoarse voice, since yesterday it has gone bad.
Yeah, that's good. So it was a
हम लोग
wonderful.
3 बजे मीटिंग है 3 बजे हाँ तो मैं रेस्ट ही कर लूंगा तो
हाँ यश तू रेस्ट कर ले लेकिन म्यूट भी कर ले मेरे भाई. Anyways, so it was a great talk, and I'm sure all the fellows and trainees have learned a lot, just like me. One thing I would like to inquire, when you would suggest a skeletal survey, what form of X-ray features you would say, no, let's go beyond the site of pain and let's do the skeletal survey?
So something which is not fitting into picture, or within a single radiograph, if you start to see multiple lesions. So once in a single bone, if yours has been radiographed and you already see 2 to 3 lesions, and you know this is something which can be multiple in etiology, so it would be better to have a skeletal survey done in that case. Or in some really atypical features, like it might not be a lesion, it might be a dysplasia which you are looking at. In that case, if you do a skeletal survey, you would be able to identify, because in that cases, you might be able to decide whether it's more of a lower limb predominant involvement. So in such cases, you would come to a better diagnosis with a skeletal survey.
So that's absolutely right. So we have seen that for eosinophilic granuloma, for neuroblastoma secondaries, and sometimes from AV malformations also, the patients would have multiple lesions. So one must remember that these are the places when we would suggest skeletal survey to define. Yes, Joanne, any questions from the...
Molen, hello.
Yes, please.
Yeah, Molen, PN Gupta.
Yes, sir.
Morning, everybody.
Morning,
I
sir.
have only one question. Sometimes, you get a picture where there is some bone pain sometimes, and somebody has given antibiotics, and there is a lot of lysis and a periosteal reaction. Now, there is sometimes a lot of confusion between osteomyelitis, which has been partially treated, and heaving sarcoma. So, any tips and tricks to sort of differentiate between these two? Because what you had shown was a clear-cut chronic osteomyelitis on the radiographs. So that is easily identifiable. But sometimes you
So that's really difficult, and we do face that in our practice also. And sometimes in such cases, history and any prior radiographs which have been done are also very important. So with radiographs, I feel as radiologists, we really don't get hand onto it, but I think you would be better getting hand onto it. So if you have prior and you can see
picture,
how the
which,
changes have
so I get
happened.
confused.
Yeah.
And other thing is
Hello,
then
sorry. There was a call in between, so I lost my net. So can you
okay.
please repeat that?
So what I feel in such a case, if you have a prior radiograph, it will make a real major difference in what you're thinking. How it has changed and how it has evolved will give you a lot of picture on the radiographs if you are talking of. But otherwise, we can do an additional MRI in such a case, which will really help us in differentiating the two. We might not limit ourselves to radiographs, but the first step should be to look for the prior radiographs, I think, which would be really easily accessible to you guys than us.
I agree with that.
Maureen,
Not a
can I
time.
add something,
Yeah,
Maureen?
Yes.
Yeah.
Who is this?
Hi, I'm Mandeep. Yeah.
Mandip.
So, yes. So see here, usually, these kind of cases where if someone has already considered that this is osteomyelitis and treated them partially with antibiotics, if it was not an osteomyelitis, it was not going to respond to antibiotics anyways. So, usually the sarcomas would not respond to antibiotics or any sort of treatment which has been done considering that this is osteomyelitis. That is one thing. Secondly, you are not going to do a definitive treatment without establishing the diagnosis by doing a biopsy in any case. So usually based on radiograph, you are not going to take any major decisions. You're going to take your decisions based on X-ray, clinical history, MRI, and a biopsy. So that question particularly, would not, make any challenge for the definitive treatment because you are going to do biopsy anyways.
Right. So the purpose of this talk and the
I
homework
agree.
for
Yeah.
yeah.
So,
Right.
Malin, can I add? Actually, mine is a very high volume center. So I'm with the Government Medical College and Hospital, Chandigarh. Now, sometimes, you get patients where there is some doubtful history of fever, lot of bone pain, and some bone pain. And, somebody else somewhere has given some antibiotics, sometimes in suboptimal dose as well. So you get a patient around 10, 12 days down the line where there is no discharging sinus or no sort of abscess identifiable. So those are the cases which cause a lot of confusion. Of course, I agree with Mandeep that you need to establish the diagnosis with a biopsy if you have a doubt. But what I want to ask Dr. Ankita is that are there any sort of, apart from MRI in the X-rays, I mean, do you have something which can really differentiate between the two? Because I do get a case, something like this about once in 2 months.
So I completely agree with you. It's a very confusing situation if you have only radiographs. So in my experience, what I've seen is that usually if I get a prior radiograph, I become a little wiser because I can then compare and see to it that is there any change? Is there some cortical destruction which is happening? Is there some change in the periosteal reaction? Otherwise, it's like if it's a very short interval, then you might not even see those changes coming up so early on the radiographs as well. So that might be a situation which would be a trick situation, and which you might so your answer would always lie between those classic features of white zone of transition and the periosteal reaction only. But the answer depends if you can get hold of the prior radiographs, or if you start to see some new additional features which can point you towards a other diagnosis than the one.
So, as
No,
we
no,
are running
Ankita, it was
short
a
of
great
time,
talk. I mean, might have to leave in between because I need to
Yeah.
scrub for the case, but it was wonderful listening to you.
yeah, that's a great talk. Now, because we are short of time, Joyance, we would move forward. The homework for you is there's a great talk. So you summarize and provide us 2-page summary of this, that how to read an X-ray and how to, the common diagnosis in pediatrics. And when we can circulate this to, yes, based on Ankita's slides, which is very nice, we can circulate to all the fellows, and that will make a uniform, language of how to read a pediatric tumor X-ray. So Ankita, thanks for that lovely talk. You can stop sharing, and we are already recording this, so we'll have a look at it again. Dr. Pal, your comment is well taken. By the time we, take Malindi's talk, Dr. Pal is from, Professor Pal is from Calcutta, and he is a professor there. Yes, diaphyseal osteomyelitis. I asked this question to my fellows. Two places when we saw this diaphyseal osteomyelitis is one is a pan-osseous osteomyelitis, and some rarely there are post-salmonella osteomyelitis we see. So you are right that mostly osteomyelitis are metaphyseal lesions. Yes, Malindi, you can start your talk.
Thank you. I'll just share the screen.
Colleagues from Bangladesh, they are checking, they're running their clinics, and they're looking at your presentation. So multitasking,
Thank you so much for this invite today to be part of this. What we are going to do over the next 20 minutes is look at how to read MRI of pediatric bone tumors. We all agree that MRI has made a really big difference to imaging of tumors. But having said that, the usefulness of MRI is always directly proportional to the quality of the scan. And it does happen that the right protocol has to be done, the right sequences have to be done. Otherwise, then it becomes difficult to give the right information. So what we are going to do is first just look at why do we really need MRI in a bone tumor? How do we scan? Like what do we make sure sequences are there? And then how do we approach the MRI? So as Ankita already said, radiographs are the first step, because nowadays the trend is often we get references for MRI even before a X-ray has been done. But whenever we are looking at a bone lesion, even then it's important to get a radiograph done and to always look at the radiograph, which should be the first step. Following that, MRI, when we need? One, when on radiograph, it looks non-aggressive, but the etiology is undetermined. You're not sure what you're dealing with. Or when it is an aggressive lesion on radiograph, then you need to do MRI for the staging. And ideally, we would want to do MRI before the biopsy for a few reasons. Because one, the biopsy can be targeted to the solid component, not to the cystic or necrotic area. Two, because the biopsy itself will lead to changes like hemorrhage within the tumor. So ideally, we would want the biopsy to be done after the MRI. Local staging, when we look at, we are looking at the extent of the marrow involvement. Is the epiphysis involved in children? Are there skip metastasis? As well as, is the joint involved, the muscle compartments which are involved, and the neurovascular bundle. And all of these can be shown very well with MRI. So before I go ahead, let me just talk a little about the sequences. Because unlike radiograph, which is AP and lateral, unlike CT, which is just plain and contrast, MR is more complicated and you have many sequences, which is always a bit confusing to everyone. So if we look at tumor imaging, we are primarily looking at three sequences. One is a T1 weighted image, which is here, T2 weighted image, and a T2 fat saturated or a STIR, STIR image. Why do we need all these sequences? When you look at T1 weighted image, the fat is bright. You can see the subcutaneous fat, the fatty marrow is all bright. This is the joint fluid here. All these are the same patient. This bit of joint fluid here is dark. So this is a T1 weighted image. Fluid is dark, flat is bright. When I look at a T2 weighted image, the fluid now you can see here is bright, but the fat is also still bright. So I'm looking at two things. One, the lesions, the pathologies, most of them will be dark on T1. So in the background of bright fatty marrow, I can see this dark lesion very well. But when I look at T2 weighted image, the marrow is already fatty, which is bright, and most of the pathologies will have some amount of edema or increased fluid content. So they all look, majority of them look more bright on T2. Bright marrow, bright lesion, I can't differentiate between them. So I need to find a way which is a T2 weighted image where fluid remains bright, but I need to make the fat dark. And that's when we have the fat saturated T2 weighted image or a STIR image, either of the two, where the fat becomes completely dark. So now whatever is the edema or the pathology will remain bright and will be standing up. So these three sequences are essential when we are looking at a tumor imaging. When I talk of internal derangement, for example, meniscal injury, ligament injury, I'm talking of proton density, another sequence, but we are not coming to that here. In tumor imaging, it has to be a combination of these, because often what happens, the wrong sequences can lead to difficulty in making a diagnosis. So what's the protocol that we use in our practice? We start with a coronal STIR image, a coronal T1 weighted image. So you can see here, this is a tumor, obviously an aggressive lesion. You can see it so well on STIR image, but there's also marrow edema. So what's the exact size of the tumor? I can make out better on this. So if you look at this epiphysis, everything looks bright. But here I can make out this is the tumor. So the tumor measurements would be ideal on a T1 weighted image because the fatty marrow really outlines the tumor well. Then we would do axial STIR or T2 fat sat, both are equivalent. T1 as well as T2. Now this is very important. We need plain T2 sequence also. Often you end up with scans which have only T1 and STIR images. But remember, STIR, the fat is suppressed and the lesion intensity also is different. So we need T2 weighted image to see whether the lesion is bright or dark on T2 image. Also, if you notice, fat gives good outline. So you can see neurovascular structure involvement, intermuscular planes well on that. STIR shows you the pathology, but everything else looks dark. T2 kind of is a in between these two. So you can see the neurovascular structure still well. You can still see the bright tumor. So you need a combination of this. A sagittal plane, again, depending on where the lesion is located, you may do it a STIR or T2. And it's very important to always have a scan which includes the other joint also. So if I'm scanning the knee joint, the lesion is in the femur, we end with a coronal STIR image, which is including the hip joint also. After that, we do contrast images, where after injection of gadolinium, we obtain fat saturated T1 weighted image. So whatever the tumor will take up contrast and the areas of necrosis, cystic component can be seen well. The important thing is these images should be obtained with the smallest possible field of view. So what happens is there is pain in the entire leg and you may obtain an image like this. Now this shows me that there is some bright signal in the proximal fibula, yes. But when your field of view is large, for example, when you click a picture, when it is too large a picture, the individual people are very small. So the resolution is very poor. This is something we need to keep in mind. After this sequence, because first when you start the scan, a child, the entire leg is painful. But after that, you need to reduce the field of volume and make sure you're concentrating on this area. Otherwise, if you still do it with a large field of view, the spatial resolution is poor and you can't make out the finer details. So this is something we all need to keep in mind. You imagine 3 orthogonal planes. You always include a joint because sometimes you end up getting a scan of just the mid tibia, without any proximal or distal end, and you don't know where you are located. It's always important to place a pain marker. We use a vitamin E capsule, or you have commercially available capsules at the point of the swelling or at the point of the pain, because then we are sure that we are covering that area. We know that we are looking at that area again. There can be small subtle lesions. So how do we start looking at the MR? Okay, now we have done an MR with the good quality following all of these things. We have the right sequences. So I think the first thing we start looking at is the lesion well-defined, ill-defined? But it's not like X-ray. A well-defined lesion does not exclude malignancy. An ill-defined lesion on MR does not mean it is malignancy. So the zone of transition is what applies to the radiograph, not to the X-ray. X-ray, well-defined, ill-defined, yes, it will help you, but it's not the main thing differentiating aggressive and non-aggressive lesions. That's something we need to keep in mind. We start looking at the matrix. Does this lesion have any matrix? How does this matrix look on MR? This is how cartilaginous matrix, chondroid matrix looks on MR. This was a child with multiple enchondromas. They are bright on T2 and they have this kind of lobulated margin, if you can see. That's very typical of a chondroid matrix. We can confidently say on MR, this is a chondroid lesion most of the times. On contrast, if contrast is given, then you have little peripheral as well as small nodular central areas of enhancement. So this is how chondroid matrix looks. If I look for osteoid matrix, it's dark on all this. This is T2 stir images, T2 fat sat or stir image. This is T1. T1, the lesion looks iso, like it looks just gray, but the extent is seen very well on the T1 meta. Here I have dark signal within the tumor on all the sequences, T1 as well as the T2 and stir images. That tells me this is osteoid matrix. So very clearly, this is an osteogenic sarcoma. Fibrous matrix. So here there's a lesion. The radiograph itself tells it's an osteofibrous dysplasia. When you do an MR, it's not as bright like fluid on T2. It is a bit of grayish. On T1, as I said, most of the lesions look kind of gray. And on contrast, it is showing homogeneous enhancement. A cyst would show you only the wall enhancing. Central portion does not enhance. So this is osteofibrous dysplasia. Next, we look at marrow edema. Remember, if you have too much of marrow edema and the lesion is very small, it's very likely that it's not malignant. That's kind of a clue. For example, this is the radiograph. Patient came with pain in the left hip joint and the radiograph was not showing much. When you look at MR, there's a lot of marrow edema in the femoral neck. There is adjoining soft tissue edema. This we see often on MR, and we have to look very carefully, and you see a small osteoid osteoma. Now, what happens if the sections are thicker? You may miss it. This may not be included. These are just few millimeter. So anytime on MR, you have unexplained marrow edema. Always it's wise to take CT cuts, and you will clearly see the osteoid osteoma well. So when you have a lot of marrow edema, first look, oh, is it something infection? Is it something tumor? You know, something which is worrying you, but you don't see a lesion. Then remember, osteoid osteoma is a possibility. Similarly, a lesion where the lesion is small, but look at the amount of marrow edema. You see how much of soft tissue edema is there. This is a chondroblastoma, lesion in the epiphysis. So osteoid osteoma, chondroblastomas are two lesions typically, and even osteoid osteoblastoma. These three things where you have the marrow edema much disproportionate to the size of the lesion. Next, we look for fat within the lesion. If you see fat in an untreated lesion, then very few times lymphoma is something which may show it. But other than that, you know that this is something non-aggressive. Benign lesion or a tumor mimic, but not an aggressive tumor. How do we identify fat? Here, this lesion in the calcaneum on T1 is bright. On stir, it is becoming darker. On stir, where the fat is getting suppressed, it is becoming darker. So I know this is an intraosseous lipoma without doubt. So MR can characterize fat very confidently. Or I have a lesion like this. Again, a lot of marrow edema. I'm worried. Is this Ewing sarcoma? When I look at this stir image, it looks scary. Look at T1 weighted image. You can see the serpentine areas and you can see the fat spared in between. So again, kind of answering the question that Dr. Gupta asked when between infection and tumor. So this is a very important point where you have fat interspersed. Fat will not be spared in Ewing sarcoma where there is an infiltrating lesion. And also you have abscess fluid here. But this fat, when you see interspersed, you are sure that this is not aggressive, except as I said, very rarely lymphoma can still cause it. Next important thing is blood fluid levels are not specific. Just seeing blood fluid levels doesn't make it aneurysmal bone cyst. Here you can see T1 weighted image shows you a lesion in the calcaneum. It tells you the cortex is all intact. It's not an aggressive lesion. There is no extraosseous soft tissue component. But within it, it doesn't tell me much. So that's T1 weighted image for you. Fat outlines pathology. You can see the pathology well, but what exactly is the pathology is seen better on the T2 or fat saturated T2 weighted image. It shows me blood fluid levels. Now, when I have blood fluid levels like this, it's an aneurysmal bone cyst is what I'm thinking. But it can be a primary one. It can be a secondary one. So for that, I try to see, am I seeing any soft tissue component? Are these blood fluid levels kind of continuous? And ideally for that, I would want to give contrast to see whether it is just smooth enhancement of these cystic components or do I have solid enhancing areas? Because blood fluid levels can be seen with giant cell tumor, can be seen with chondroblastoma, can be seen with adamantinoma. So there's a whole bunch of tumors which will show you blood fluid levels and you need to identify the solid areas. We need to remember that certain areas in the bones in the body are epiphyseal equivalent. For example, patella, calcaneus, and apophysis. So you can have chondroblastomas, you can have giant cell tumors in these locations. So the epiphyseal tumors would be there in the apophysis. Certain times you have radiograph like this, which again, you're not sure what is happening. So again, one view is no view. The other view is clearly showing this is an osteochondroma. Why would you do MR in this? Because it's clearly an osteochondroma. It can be if there's a sudden increase in the size, if there's sudden pain, then I want to look for this cartilage thickness. So the cartilage thickness can be evaluated very well on MRI. And if there is malignant transformation, that can be seen. But remember, in pediatric age group, in the growing skeleton, these can look very heterogeneous. So this bright signal is not to be worried about. It's only the cartilaginous thickness and smoothness bone destruction. And then one more, which I think is very important, which tends to get, can be missed if one is not careful. When I look at this MR, it's very hypo. All the bone looks very hypo. Remember, as soon as the ossification center is formed, it is fatty and it remains fatty throughout. Here, the epiphysis also in this child just came with some minor trauma, fell off a swing in the school. And you have diffuse dark T1 weighted signal, T1 weighted image hypointense signal, which is bright on stir. And just to show the same age normal child, MR, this is the normal fatty marrow in the femoral head. This is red marrow, which can get confusing. So if I just look at stir, I'm not sure, is this red marrow, is it not? But I look at T1 weighted image, it's very dark. This is leukemia. And we obviously don't want to miss this. So just the last few slides where we have, so I think I have about last 4-5 minutes. You have radiograph like this, and it's an incidentally detected lesion, but often nowadays people want an MRI to be sure, though this is not needed. The radiograph itself clearly shows it's a non-aggressive lesion. But if you do an MR, you kind of confirm it. This is non-ossifying fibroma looking hypointense. So on T2 weighted image, it is showing dark areas, suggesting fibrous component. It's cortical, well-defined. But in this child with multiple non-ossifying fibroma, MR still helped because this one had a stress reaction. There was edema. So it could kind of be explained, this is what is causing the pain which they were worried about. Sometimes, rarely, you have these larger non-ossifying fibroma, which had in fact fracture. These are much less common. Most of the time they are incidental, but this one did have fracture and an MR was done to show that. You can clearly see the lesion is only cortical, well-defined. This patient has an osteogenic sarcoma, and then radiograph, there was this lesion, which on MR shows you is a non-ossifying fibroma. So you have non-aggressive incidental lesions, but sometimes an MR would be helpful in confirming it. Usually it's the radiograph, don't touch lesion. You may not need to do an MRI, but if needed, yes, it can confirm it. This patient with a large pathologic fracture, again, you know it's a well-defined lesion, MR confirms there's a blood fluid level, it's a cystic lesion, and see the contrast enhanced. It is only peripheral enhanced. So this is a simple bone cyst which had a fracture. Another lesion now looks little more kind of trabeculated appearance. There's a pathologic fracture. Again, this is because of the fracture that you have hemorrhage, but otherwise this is still a simple bone cyst. You have just simple peripheral enhancement. This heterogeneity is because of the hemorrhage. So you can have these atypical appearances of SBC, and one may do an MRI to confirm it. Here on this radiograph, child came with, the child was not moving one limb, and you just see some periosteal reaction. That's it. You don't know what is happening. On the radiograph, you're not sure. And MR shows you this turned out to be Ewing sarcoma. There's a large lesion. You can see the marrow extent. You can see the soft tissue. And again, the question on MR, is it infection? Is it tumor? The clue is soft tissue edema. So on infection, you will have much more soft tissue edema. In Ewing sarcoma, you have lesser of a soft tissue edema. Also, fluid signal. That if you give contrast, this will be more an abscess fluid, while this will be solid. Here, the MR clearly, X-ray really shows it's an aggressive lesion. There's no doubt about that. But what is MR adding? MR is adding that there is involvement of the joint. MR is adding encasement of the neurovascular bundle. MR is showing involvement of the tibia, which the radiograph is not showing. So for the staging, the extent, MR is really useful. And MR can show you skip lesions also, which on radiograph may not be picked up till 50% of the bone is destroyed. So you have a lesion, and you also have a lesion with normal marrow in between. And the last one where X-ray looks normal, pain still persisted, a repeat X-ray barely, it shows soft tissue and some change here. This was the initial X-ray 5 months before, and MR confirms that this is an aggressive tumor. Do we need contrast? Yes, to distinguish solid from cystic component. On routine MR, it may not always be possible. Edema versus tumor, MR may not help because edema may also enhance a bit. Primary versus secondary ABC, we already talked about it. Post-treatment. So this is Ewing sarcoma pre-treatment, and this is post-chemotherapy. You can significantly see complete resolution of the soft tissue component, and the lesion itself also is smaller. Even with metal, you can do MR. So often what happens, we look at the X-ray and we think, oh, we can't do MR. No, we can do MRI. There will be artifacts, but how much artifact we can't determine on the X-ray, because based on the material that is used for the implant, it can be variable. So we can always try how much artifact is there. And even if you can't see just the adjoining marrow, clearly you can see a recurrent lesion out here. So with metal, MR is still possible. CT, I would end with this slide. This child came to us with neck pain. And what we saw was this vertebral body showing dark T1 and slight hyperintense signal. When we gave contrast, you can see on these axial images, there was a lot of epidural soft tissue, we thought, which was encasing the vertebral artery. It's going all the way into the neural foramen from C4 to T1. You can see this soft tissue-like thing. So we were really worried. But the bone was involved, marrow edema was only one location. Is this infection? Why is there so much of epidural soft tissue? And as I said, when you can't explain what is happening on MRI, a CT always helps you. And this was an osteoid osteoma. And that was just all the reactive edema, which was looking like an epidural soft tissue. Correct scan protocol, location and age, just like on X-ray. MR signal intensity. Is it fat? Is it cystic? Is it solid? Extent, MR shows you the best, and contrast is always helpful. Thank you.
Thank you very much. So, Johannes, you can take questions. A few questions.
Thank you, ma'am, for your talk. We have a few questions. First is, what are the MRI signs of malignant transformation of osteochondroma?
So osteochondroma, one is the thickness of the cartilage, which normally is less than 1.6 centimeter, but it's not absolute figures. Because especially in children in growing skeleton, you may see a bit of heterogeneity within the osteochondroma itself, but the thickness, is it smooth or not? Is there any bone destruction and extraosseous soft tissue component?
Okay, thank you, ma'am. Somebody has asked to share the staging system for bone tumors.
Okay, I didn't include because of the timing but But you have multiple staging systems. Depending on which one you want to follow, basically you're looking at compartment involvement. Is it only in the bone? Is there cortical erosion? Is there extraosseous soft tissue component? That extraosseous soft tissue component, which compartments is it involving? Is the neurovascular so again, neurovascular structures, whether they are encased, involved, or just abutted with loss of fat plane. Then you are looking at joint extension and you are looking at epiphyseal extension. So all of this, when you describe the staging system, whichever one, because there are many of them, whichever one commonly used, you can put it into that.
Thank you, ma'am. Another is when is a CT necessary after MRI, apart from suspected osteoid-osteoma?
Yeah. So just from practical experience, I would say anytime we have marrow edema, which we are not able to explain, whether osteoid-osteoma or not. But when you have marrow stir hyperintense signal, which we are not able to explain, getting CT cuts always helps us in that situation. This has been like so many times, getting CT cuts in those cases always makes us wiser. It could be something like a stress fracture. It could be osteoid-osteoma. Otherwise, some people take CT cuts in all the tumors, may not be essential, because things like cortical destruction, erosion, all of that can be made out on MR well, and you have radiograph with it to look for the matrix and all that. So if you could, means if you do it, fine, but if you don't also, but important thing is, where on MR things are not clear, taking CT cuts always helps.
So that was a great talk, and we have few quick, interesting cases, and that would appeal to all the delegates. So all the other questions we can take later, and we can inquire with the team. Joyance, would you like to share your screen and start presenting?
Yes.
That was a great talk, Dr. Malini. Now, these are the cases which baffled us, and would like to present and take your opinion. And then we will show what we did and what we found. Yeah.
So I'll start with the first case. We had a 12-year-old boy. He presented to us with a sudden onset of right arm pain, which started after he was playing. He was throwing a ball, and the pain started, and there was no prior injury, no prior history of fever or swelling prior to the onset of pain. On examination, there was no swelling or erythema in the arm or mid-arm. There was some tenderness in the mid-arm anterolaterally. Both the elbow and forearm shoulder movements were normal. So we got an X-ray of the arm done, and these are his initial radiographs.
So can you show these zoom in views? Yeah, so I'll take help of Ankur. Are you there with us?
Yeah.
Yeah, so
So-
please have a look and suggest that what are the possibilities we should think.
So as Ankita showed, this lesion it is a relatively well demarcated lesion with looks like a narrow zone of transition. There are areas of sclerosis at the periphery, but at the same time, it is an osteolytic lesion, but it is causing some endosteal scalloping, which we don't see routinely in all the benign lesions. So this is one thing which is a little alarming. Apart from the osteolytic lesion, the matrix shows areas of some calcification, which look like at the periphery, like some rings. And with this endosteal scalloping, we need to think about probably a chondromatous lesion also, which can be a little aggressive because of the endosteal scalloping in a long bone.
Okay. Any Ankita, any other views on this? I mean, of course, we agree with what Ankur says.
Yeah, so I agree with whatever Ankur sir mentioned. Just that because of this atypical location in diaphysis in pediatrics, usually not much lesions are there. So I would also keep a differential of EG over here.
Right.
Yeah, I would think of eosinophilic granuloma also significantly because of the endosteal scalloping, the way the appearance is.
Yeah. So when you suspect EG, would you like to do a skeletal survey to see a vertebra plana or other lesions, or you would go for an MR right away? What do you do?
What I think is that doing an MRI first, and if you think again in the same lines and not any other lines, then a skeletal survey
Then you
would
do a skeletal
more.
survey. Right, Malini, do you have anything to add to what this?
No, I would agree. I would say that an MR first would be a better idea rather than getting a whole skeletal survey.
Yeah. So, Mandeep, are you still driving or you're with us?
No, I am here.
So Mandeep, can you tell us as a clinician, when you see such path fracture through a lesion in the diaphysis or mid-shaft of a child, what differentials you would think?
Of course, as the other panelists said, EG is one of the differentials. But see, this is too well demarcated for me to be an EG. We have seen EGs to be a little kind of an intermediate kind of a thing between benign and malignant, where you can see the zone of transition sometimes is not this sharp. And many times we have seen more destruction as compared to these as compared to this particular lesion. Secondly, the matrix that we see here, a little bit of fibrous or some sort of, you see in the proximal part of the lesion, you see some ground glass type of a matrix. And this see, I would be a little biased because I was part of the treatment of this patient.
Yeah,
but even before we did the biopsy, our differentials did include BFH. Our differentials did include BFH or an ABC. Of course, I had seen the MRI by that time. But
Mandeep, you stop there. Now, being a clinician, when a patient, I'm not a tumor surgeon, but any ABC before they fracture, 95% of time they present with the pain, and not because of path fracture, but because of the aggressive lesion they are.
Correct.
So here it was not the case. The patient came because after trauma. That this is a history we see mainly in SBC, but this is not a common site for SBC. And eosinophilic granuloma, again, we have seldom, very rarely, we have seen a path fracture through an EG. Most of the times they have pain because of their expansion. So it was confusion. Yes, Joanne, you can move ahead. What we thought primarily.
Okay. So as discussed, we had kept these as our differentials. And
so tuberculosis we have seen, whenever we see tuberculosis in a bone, it comes as they might present as a cystic lesion, and they are not symptomatic for long because it's a very slowly growing organism. So this is what we see sometimes. So this was one of the differentials. And let's just move on to what we did further. So let's show the MRI images. So Malini, you can explain to us what these imaging are.
Yeah, so there are the lesion, the appearance is like on radiograph, how we said there's endosteal scalloping, all of that. So it's not EG because EG would have more of marrow edema. Also, it has many T2 dark areas which would fit into a fibrous content. Fibrous that, because EG I would expect much more marrow edema than this. It's a well-defined lesion. There is no there's endosteal scalloping, but no extraosseous soft tissue component. It's not eroded through the cortex. And this, I think, is the FATSAT T2 image, and I don't see much of marrow edema. So I would go with a fibrous lesion.
Yeah, can you go ahead with another images? Yeah, no, this is, I think, T2.
Actually, I think that was T2 and this is FATSAT.
Acha, this is FATSAT.
Yes.
But just can you go back one slide?
That a little bit.
Okay, here it was all looking dark, so I was thinking that this is okay.
So for orthopedic surgeons, T2 is our friend because we see all white. But yeah.
So
T2
on
also
this,
has to be either T2 FATSAT or a plain T2.
yeah,
So
and also obviously we'll see all on the screen. Normally we'll not see one images like this. So yes, here there is marrow edema.
No, but this edema could also be because of path fracture.
Yeah, edema could be because of path fracture because the appearance itself is more like a fibrous.
Yeah, do you have another image, Johannes?
what I was wondering is, do we see some fluid levels on that T2? But it was not very clear on the first image.
Unless we have axials.
I know we need to see the axials. Otherwise,
it can whether this is a fluid
ABC transformation in an FD, which had fractured. Is one.
Johannes, can you show the axial?
We have.
Can you zoom this a bit? Possibly.
Can we zoom it? I don't think we can.
I think these are clicked images, so probably it will be
Yeah.
a little difficult to appreciate the
Difficult, and also what happens, we can't
internal
window it also
structure.
to
Yeah,
check
we
for,
can't window it. So
like this looks all bright, but on windowing, there could be blood fluid levels.
there is
So in
some
nutshell,
soft tissue edema as well. Again, could be because of the fracture.
So in nutshell, we all were confused, that this is not a typical thing. And so the next step was to involve Mandeep and to take a biopsy. Yeah, Joanne, just can you move ahead than what we did? Mandeep, any other thing you want to add?
No, I think any benign, even if it looks benign, there are any aggressive features here, you have to do a biopsy. There is no direct treatment of this lesion. That's the message.
Yeah.
There is always a biopsy. Even if you are 100% sure this is ABC, you still have to do a biopsy. Now, the only lesions where you could probably treat without a biopsy are the classical osteomas or vascular malformations, or maybe sometimes a simple bone cyst. And fibrous dysplasias, of course. But otherwise, all the other lesions you have to do a biopsy. That's a rule.
Yeah, Joanne, let's move ahead.
Okay,
For ABC, isn't that a very atypical location? It was like completely mid-diaphysial.
Yeah, of course. So even those fibrous areas, within on the X-ray as well as on the MRI. So honestly, my first differential was a benign fibrous histiocytoma because of the classical location. This is a very classical location for a BFH, which is a mid-diaphysis.
Yes, sir, that I agree. Because SBC, most common differential also we encounter is FD only in the same location.
Even the bone expansion is not very extensive, what we see in the.
Yeah, that endosteal scalloping is actually
Just scalloping, yeah.
So let's move ahead because this was not a very, what we found on biopsy is, Joanne's.
Yes. So the core needle biopsy, the histopath report came as suggestive of it had large features of solid aneurysm bone cyst. So this one article published from AIMS New Delhi, published in JCDR 2017. So solid variant of the aneurysmal bone cyst, it's very uncommon in less than 10% of all the ABCs, and it's also diagnostically, it's a challenging
go back.
diagnosis.
Sorry to cut you off. Please go back to the biopsy report. Yeah, so it's basically BFH, which has a secondary ABC-like area.
So benign fibrous histiocytoma, yeah?
Yeah, go ahead. No problem.
Okay. So we decided to proceed further, and we did an extended curettage. We actually removed a cortical bone window, did an extended curettage, and then we fixed back the window with a screw, and then we used a plate as a neutralizing plate. This is the immediate post-op, and this is 1 year follow-up of the same boy. And this is his functional outcome. And then he later underwent implant removal.
Yeah, so Mandeep, would you like to say a word about how this BFH or what is solid ABC and what is the line of treatment? Is the only line of treatment? Because the paper of AIMS, they have done intercalary resection with very extensive involvement, and then they did the grafting and plating. Just a quick word about treatment.
It's like any other benign aggressive lesions. This is treated with intralesional surgery as far as possible. If the lesion is too big and not amenable to curettage, then resection is done. Otherwise, the treatment is surgery. Now, for a solid ABC, there is another way of treating it is something called sclerotherapy. Now, solid ABCs don't respond to sclerotherapy as much as well as the conventional ABCs respond to. And that is why solid ABC we sometimes suggest the patient, especially if he's almost at the teenage or at the end of his skeletal maturity cycle, to go for surgery even if it is an ABC. In younger patient with solid ABC, we would probably take a chance with one or two shots of sclerotherapy, and if it doesn't respond, we can go for surgery. But in BFH, the only answer is surgery.
So BFH was a new term for us pediatric orthopedicians, benign fibrous histiocytoma or a solid ABC. So this should be considered, and the key is we have to get into biopsy and the treatment. Yes, let's move on to the next case. So Tashwin is presenting, or Joyance, you are?
So Tashwin is
Tashwin, yes,
sharing.
please.
So we have second case. So we had a 4-year-old boy with right hip pain for 1 week, and there is no history of fever or night pains, but history of trivial fall. On examination, we found tenderness at proximal thigh and mild thigh atrophy, and there is a terminal abduction restriction right here. So this was the initial radiograph.
Yeah, go ahead and show the zoom in view and this lateral. Okay, so Ankur,
Yeah,
just
again, so
read this X-ray for us, and again, this was a bit confusing picture because this is intramedullary and intracortical also, and
again, a
was not.
well-demarcated lesion with narrow
Yeah.
zone of transition, but there is areas of cortical thinning and even some minimal periosteal reaction also probably at the medial aspect of the lesion, which is
Yeah.
extending up to the cortex, but can't see any significant extraosseous soft tissue component or
Right.
defect in the bone.
So what possibilities you would think based on this X-ray?
In looks like not a completely non-aggressive lesion because it is causing significant again thinning of the cortex and some minimal periosteal reaction, but we need to do an MR probably for the lesion.
Yes, that's right. But if like, what would you suggest the fellows that when you see such lesion, the one thing is it certainly needs further imaging to come to a conclusion. What things they can think about it? Anyways,
Again,
yeah.
So, Maulin, can I add here something?
No, you cannot add
So,
anything because you have done this
okay,
case with us.
okay, sure.
You give a final comment. Anyways, Ankita or Malini, and can you tell us what differentials we should think here? Of
So,
course, we are going to go for further imaging, but
still, I was thinking more in terms of a non-aggressive etiology as such, because there is no cortical erosion. It just feels like more of an attenuation, just as Ankur sir mentioned. So I would think of something like a juxtacortical kind of a lesion, maybe a OFT or something like in terms of osteofibrous dysplasia in those lines, because the matrix looks a little lytic or a little ground glass at areas. I'm not really. I'm so sorry. I'm not really thinking of a very aggressive etiology. Uh, just that the location is at the almost at the level of the lesser trochanter, so which makes it a little lytic area in the lesser trochanteric region is better to get a further evaluation, is what I think.
yes, Mandeep, what would you want to say?
So this is primarily a cortical lesion. That is what I can see from the X-ray. This is a cortical lesion with scalloping of the cortex or the endosteal side, on the endosteal side. I don't think there is medullary involvement here, even on the X-ray, because if you see the inner zone of transition also very sharply demarcated with some sclerosis. So I think there is buttressing of this lesion is buttressing the inner cortex towards medulla, but there is no medullary involvement. Of course, MRI will tell us exactly what it is, but this is what I can see from the X-ray.
So
So
that
this is
is
primarily cortical lesion, and that
Hmm.
is where you can narrow down your differentials to
So
cortical.
that's what you say based on the lateral X-ray, I think, yeah. Because on AP it looks like it is going in, but there is a shadow. Let's go on to MRI and Joanne, what we thought primarily as possibility in this case. Can you move ahead?
As discussed, sir, we found we had some differential diagnosis. One is simple bone cyst, fibrous dysplasia, non-ossifying fibroma, and eosinophilic granuloma and tuberculosis.
So there are plus and minus points for all this diagnosis based on this X-ray, but these few things came to our mind when we saw this image. And let's move on to the imaging, further imaging. Yeah.
This is an MRI.
Yeah. Do you have the axial images also?
Yeah, show further images if you have. Move ahead.
Yeah, so this is a cortical lesion, as we saw on radiograph. This is a cortical lesion, very well defined. Again, there is no extraosseous extension. Medulla is normal. If you can just go back, was there any marrow edema or one section behind? One more slide.
Yeah, there is some marrow
I'm
edema.
not able to. Maybe we have more axial images which can help us.
Yeah.
Yeah, we can go ahead.
Do you have any? Is there a fluid level, ma'am?
We'll need to little zoom up. I think there is one.
That is one probably in the lower
Yeah,
image.
that's
First,
one there in the dependent
first below
position
image,
here.
yeah.
Yeah.
Pauline, do we have contrast enhanced images here? Do we have contrast images?
There's a fluid level for sure.
Fluid level, yeah.
Let me, Tashvin, do we have any? Have you put any other image?
No, sir.
But Tashvin thought you all are so smart to find out from this image. Anyways, but what I remember is even after these images, me and Mandeep were not very clear that what this is exactly. Am I right, Mandeep? And then we had to move ahead with.
Yeah. One we can say is it's non-aggressive.
And
two, it's a cystic lesion with a fluid level with it.
Blood fluid level.
So here the dilemma was this, because of the same single fluid level that we saw, we were thinking of a cortical or surface ABC. But here again, it was an incidental finding because child did not have any pain. He was just limping, and that is how this was detected. And that is kind of a little unusual with ABCs. Usually they are
the cause
painful.
for the limp was something else established, or?
No, I think with this lesion, the patient, see, whenever they have pain around thigh, they can be referred to the upper thigh, lower thigh, knee, or proximal leg also. And he had some symptom, the effusion, and had some limitation of terminal motion because of this. So the pain is because of this only. It's not because of some other problem like viral. Because
this is exactly at the insertion of the iliopsoas. So
Yeah.
there is
This is the lesser trochanteric lesion.
Yeah.
The lesser trochanter has got expanded.
And before coming to us, patient has already received anti-inflammatories for 2-3 weeks. So, and then still the pain was there. So it was not any, inflammatory pain. Anyway, so Mandeep, what was your thought process while dealing with this? Just let us know.
So of course, so this was a thought process that we are looking at something which is certainly not very aggressive. This is not malignant. It is certainly benign, but we wanted to document what it is, whether it's an ABC or it is an NOF or it is a CMF, what it is. And that is the reason why I did a biopsy. And
Yes,
while we were
Ashwin, you can move ahead.
And this MRI findings impression, they showed the focal osteomalacia, and we had treatment plan.
Go back to that report.
I wouldn't think of osteomyelitis because even when you have Brody's abscess or something, you'll have edema around it and all of that. It won't be so well defined like this.
I agree with that. This was not looking like osteomyelitis. There was not any soft tissue involvement, not surrounding edema, very sharp, zone. So that will not be case with infection. That should be a hazy thing. So we were not agreeing with this MR report. And so we plan to do the biopsy. Yeah. Tashvin?
So we did a coronal biopsy and periods of the lesion, and sample were sent for culture sensitive gene expert, which report negative. And we did
I'll just a second. I'll add something. While we were doing the biopsy, it was completely cystic. So just like I'm biopsying a simple bone cyst, where you have to do a you curate the walls or dislodge the walls with the help of the tip of the Jamshidi needle and then suck it out. So all we could get were certain linings, and it was certainly there was no gush of blood that we usually see with ABCs. So this was kind of a more of a primary cystic lesion. If this was a classical metaphyseal lesion, I would call it a simple bone cyst. That kind of biopsy experience was that.
Yeah, move ahead, Tashwin.
And the histopathological examination reveals there is a suggestive of aneurysmal bone cyst.
So benign solid and cystic lesion with giant cell component suggestive of ABC suggests molecular genetic testing. We did this USP6 gene rearrangement testing, but that was negative actually.
Negative.
So although
Yes.
even our histopathologist was a bit confused, so we plan to move ahead with the clinical improvement. And can you show the X-rays? And so we discussed this with the family. Tashwin, move ahead.
At present session, and after this was after 1 month of biopsy, there is resolving the reticulation, and after 3 months of biopsy, so it's almost going
So
to
this,
resolve.
we discussed with the family that if the lesion expands or symptoms worsen, we would go for an open surgery. But if it resolves, then we'll just wait and watch. And that's what happened, Mandeep. We just got this X-ray yesterday.
Right.
And patient is better. And mother said now he's playing cricket and he's asymptomatic. Absolutely. So I think your assumption was right. And this is a healing lesion. And we'll be still following this child.
So I still don't believe this was an ABC, that's for sure, because I spoke to the histopathologist and we can gauge what is the confidence level of the histopathologist. USP6 was negative. USP6 is very sensitive. It is positive in almost 97.6% of ABCs. So basically, this probably was some sort of a cystic lesion. And with our biopsy and the curopsy type of a biopsy that we usually do, very aggressive curettage of the linings or the disturbing lining very aggressively, that has helped here.
So this
and
case
our
shows
our way
the-
our method was perfect. Our method was correct to observe this patient because here only thing was that we are not looking at impending pathological fracture. Otherwise, we would have certainly done something more aggressively. But here it was you were very confident that this is not unlikely to fracture, and that is why we did wait.
So we kept him non-weight bearing for a month. And fine. So key is not, we should decondition our mind from infection or even, and should not blindly report, rely on the MR report. Otherwise you will always go open and do something. Let's move to very quickly through next two cases, Joyance. We are having only 6 minutes, so 3 minutes for each case. I would like you to just rush through.
So I'll start with the third case. So we had a 11-year-old girl. She presented with a left ankle pain, which she had since 3 months. No, she didn't have any night pains. There was no history of fever. There was no trauma. She could manage all her activities without any need of NSAIDs. She had, on examination in the OPD, she had mild swelling in the ankle. Also, we noticed some calf and thigh atrophy. There was tenderness over the anterolateral distal leg. However, the ankle and the subtalar range of motions were normal. So we got an ankle radiographs done. These are our initial radiographs.
Yeah, so there was a lytic lesion near the growth plate in the metaphysis. So the first thing I thought is infection.
True.
And yeah, Joyance, let's go further and tell the whole story.
Okay, so these were our initial differentials, and we got an MRI done to evaluate further. And due to paucity of time, I'll just rush through this thing. And initially we got a core needle biopsy done, which was inconclusive, and she came.
Can you go back one slide quickly? So although we saw some changes in the foot area, mid-tarsal area also, And so I got puzzled at this point that there's something wrong at two places, but still, as the pain was localized to ankle, I did tibial biopsy, which was kind of non-conclusive. Yeah, now you should move ahead.
So she presented to us 2 months later with persistent pain around the knee. Also, she complained of pain in the chest and head, and so we were thinking of something systemic. So we got knee radiographs done. So
Yeah. So a quick question to Ankur: what things you would think when you see this kind of X-ray?
These are multiple, almost like osteolytic lesions in distal femur as well as areas in the proximal tibia. Again, aggressive looking. Still looking at the previous ankle images as well as the knee images. One possibility which could be is multicentric, some low-grade infection, which comes to my mind. Apart from some systemic illness.
Yeah, Ankita, do you have any other thought on this? And we'll show you the MR as well in a moment.
Sir, I agree with Ankur, sir. So that would be one thing. The other thing I was thinking of CRMO, but we'll have a look at the
CRMO, we see more of sclerosis than.
Yeah, CRMO, and only thing on the MR, again, those are small images, but I was wondering if it's chondroid, something like Olliers where you have multiple lesions.
Show the MRI picture if you have.
Because on the ankle MR, it kind of looked like that. The tarsal bones and all that, in these Olliers, you have sometimes
quite bright on the fat side.
Chondroid, but they're very small images. Let's look at the knee MR also. That will probably.
Go ahead with the knee.
But this radiograph is.
Now it's a full image. I'm sure you want to see all other images, but do we have any coronal? Yeah, here it is. So any Malini, any comment on this?
Yeah, I'm just looking at it again, and this doesn't look like CRMO. Because the CRMO, you will just see ill-defined edema, but at the same time, you have multiple lesions. And again, I don't know, it still looks a little lobulated to me, like chondroid.
Yeah, chondroid
actually,
is
there's no marrow
Yeah.
edema to support
Yes.
infection.
Infection. I would still think of chondroid, multiple.
Chondroid or fibrous, with looking
Or
at
fibrous, yeah.
Yeah.
So I did open biopsy in the ankle.
Vascular?
There was
Vascular?
no.
Yeah,
Yeah,
sir,
vascular,
is
correct.
also good.
Yeah. So when I opened the ankle, it was not infective. There was no granular. There was all cartilaginous kind of thing, bluish. So either it was vascular or some cartilage-based tumor. It was.
Yeah, because that ankle, the tarsal bones which were there, the midfoot tarsal bones, they were very much like cartilaginous kind of.
Yeah. So let's move ahead, Joannes, and yeah, these are
some
Yeah, these either cartilaginous or a vascular thing. More looks like cartilage.
Yeah, go ahead, Joannes.
So, yeah, some more images. So this from the it's the first histopathology which we sent. The first report. There were islands of cartilage resembling epiphyseal plate with mildly cellular spindle cell areas and vascular proliferation. Fibrocartilaginous mesenchyma was their possibility.
And on the stains with, there was no spindle cells or for blood vessels. That's what was seen. So this report was done here, and then they send it to CMC Vellore to their mentor, Dr. Walter. Is that right? And he reviewed the slides, and he thought that it is either a fibrocartilaginous dysplasia or an enchondroma. But the patient had pain all across the body, chest wall, skull, and we sent this patient to be seen by Dr. We did one more biopsy with Mandeep. It turned out a benign chondroid tumor. So Mandeep, the patient, we sent to Dr. Puri sir in Tata.
Yes.
And Dr. Puri said that this is a multiple intraosseous AV malformations, and you don't need to worry. This will heal as a child grows. They have that benign history, and we just treat them symptomatically and protect their extremities if they are in the weight-bearing area. So that's what we did, if you remember, Mandeep. But
Yeah, I remember. Yeah.
yeah, but although her lesions resolved, it left behind the limb length discrepancy and angular deformity because it was kissing the growth plate. So she developed differential growth at the knee joint. And Joanne's tell what we
Yes.
did. Yeah.
So this was her X-ray at skeletal maturity, the scanogram. So she developed a varus deformity along with a limb length discrepancy of 3 centimeters. So she had previously undergone a contralateral epiphysiodesis with drill and also a hemiepiphysiodesis of the lateral proximal tibia. But, in spite of that, she had at maturity she had a 3 centimeter limb length discrepancy, and now she's currently in the deformity correction plus lengthening with Elizaro stage.
So, as Dr. Puri rightly said, all her lesions and pain resolved over a period of time, but it left behind these deformities and shortening, which we required to correct with a frame. So this was an interesting case. This 10 years follow up on this, Mandi, if you remember.
Yeah, this is when we were all, very young.
Yeah, but
You are still young.
we are young in terms of our knowledge. Anyways, let's go through this 4 cases. Real, I mean, I would appreciate your opinions being a tumor radiologist and surgeon. What is this, Mandeep and Malini? Just let us know. Yes, Tashveen, move ahead. Tashveen, are you there?
Sir, now
Yeah, please go ahead.
we had 3-year-old boy unable to bear weight for 1 week. Child was very irritable, and there was no history of fever, trauma, bowel and bladder incontinence, and no history of night pains and lethargy. And on examination, there is a buckling of lower limbs on supported standing. Reflexes and sensations were normal.
Varun.
And this was initial radiograph.
Yeah, so Ankita, what do you think about this X-ray? It's not a very good quality X-ray, but the patient was a bit poor and they brought this X-ray in.
In this case, actually, the metaphyses are showing little flaring and all, like we see with rickets, and more of something metabolic in addition going on to the kid. And in addition, I can see there's some fibular head osteolytic lesion, whether that's also a part of that spectrum, or if we can get x-rays of bilateral sides in this case, it would be.
Yeah, so it was present on both the sides. Similar,
Periosteal reaction also along the tibia.
Yeah, so there is a bit of
medial
periosteal
margin.
reaction, agree. There's some periosteal reaction proximal fibula as well.
But only odd thing is the distal end of femur looks fine. It doesn't show these changes.
Yeah, true.
Yeah, so this X-ray
Was
is
there,
not...
because sometimes you may even have metastasis from neuroblastoma or something, metaphyseal lesions.
Even the proximal tibia is good. It is only distal tibia fibula and
So that's
proximal
why,
fibula.
and it looks, the fibula especially looks something aggressive. So just thinking mets from neuroblastoma or something like that, because distal femur looks
Child
fine.
was quite an irritable. This is picture what we see through in some of the leukemias and in the neuroblastoma mats. We see the child is very irritable, more irritable than what we see on X-ray kind of thing. Yeah. So first we thought about any metabolic. Yeah, Tashveen, move ahead.
So we had some differentials and acute lymphoblastic leukemia, lymphoma, systemic metabolic disease, and multifocal osteomyelitis. And we did lab investigation where shows hemoglobin level is low, and lymphocyte count was high, and C-reactive protein was normal. And metabolic profile we also did, which shows rebels normal and vitamin T also normal. We also did peripheral smear also
Yeah,
normal.
so we did an expert smear check and with the pathologist, and he said there is no abnormal cells. So we are now with low hemoglobin, normal WBC, CRP normal, so there's no infection. Metabolic profile was normal calcium, phosphorus. So what do you think this is now? And smear was also normal.
So mets from neuroblastoma still remain
Yeah.
possibility.
Yeah. So we
Do we have MRI?
no,
No.
patient was extremely poor, but I'll tell you, Mandeep, we referred this child to a neurologist as well to see if there is something neurologic going on. Sometimes we see acute, myelitis, but not with these X-ray changes. And go ahead with the slide. EMG was normal, so no neurologic thing was going on. But, we realized that the status of child was that sometimes these changes are seen in scurvy. So we got this ascorbic acid level done. Tashvin, move forward, please. And the pathologist called me that ascorbic acid is not at all detected. So if you look at the x-rays, this was scurvy and we treated with vitamin C supplementation. You would be surprised that in this current phase, you see these patients, but yes, in last 1 year, we saw such 3 patients who had vitamin C deficiency. Let's move ahead with.
And this was after vitamin C supplementations.
So this you can see the organized periosteum now.
Excellent.
So hematoma,
Yes.
which was there subperiosteally, is now organized on both the femur as well as tibial side. And after 1 year, you see the X-rays, they are all normal looking X-ray. And move ahead. And the child started weight bearing and he was all fine. We have some X-rays of other very typical finding of scurvy X-ray, Tashfin.
Yes, sir.
So
This was
another child. As some of you pointed, there is lucent band over the metaphyseal. There is sclerosis, dense band, cortical thinning, periosteal elevation, which might not be seen on first X-ray, but later you see. And there is ring-like epiphysis, sclerosis of epiphysis you see. There is pathogenesis of all this, but we won't go in details. Can you move ahead?
And this is a wonderful journal which reveals MRI findings in pediatric patients with scurvy, published in 2014 on Scotland. They present the MRI findings of 4 pediatric patients with scurvy. They have shown decreased signal on T1 weighted images and increased signal on T2 weighted imaging within the bone marrow. And
yeah, so this is our radiologist sent this video. This is how scurvy looks on X-ray. There is marrow edema near the physis, some periosteal reaction because of the subperiosteal hemorrhage. And I would share a few articles on current day scurvy, Anyway, so this was just sometimes this is again a tumor mimic. So I think we would wind up at this point. I would like to thank all our faculties, Malini and Ankita, for great talks. It would be a great learning point for all of us. And Ankur and Mandeep, thanks. I think this is a great session. We'll take this will be telecasted on Ortho on our channel, so I'm sure many people would benefit from it. Thank you very much for your time.
Thank you, sir.
Thank you.
Thank you.
Thank you. Take care.